Good evening. Probably since the birth of civilization itself, the myth prevailed that the joys of motherhood cannot be experienced without passing through the acute agonies of labor. This is true no longer. The myth has been broken. Pain relief is the fundamental right of every mother during labor. The American societies, both of obstetricians and that of anesthesiologists, are quite categorical in their mandate. Every woman should have the option of adequate pain relief, and yes, typically in the form of epidural analgesia. Because epidural analgesia is now well established as the gold standard for pain relief above all else. Yes, the gold standard has its concerns that it may delay the progress of labor and increase the rates of instrumental and operative deliveries. An additional issue of controversy is that these effects are more when epidural is initiated early during labor, and hence the debate, the null hypothesis that we wanted to test in the form of a study. Does early initiation of epidural increase these effects, or it does not? At the Department of Anesthesiology at Tata Motors Hospital, we conducted a study to determine if early initiation of epidural analgesia in nulliparous women affects the progress of labor and the rates of operative and instrumental deliveries. Ours was a prospective observational study in which 304 nulliparous women were enrolled. The mothers were divided into two groups based on cervical dilatation. Those with cervical dilatation less than or equal to 3 centimeters were enrolled in the early group, while those with cervical dilatation more than 3 centimeters were enrolled in the late group. All mothers who had completed 36 weeks of gestation and in labor were enrolled at the first request to epidural analgesia after obtaining informed consent. The exclusion criteria were contraindications to epidural, medical complications like gestational hypertension, gestational diabetes, and an estimated fetal weight more than 4 kg and an abnormal fetal heart racing. An appropriate sample size was calculated. A difference in the incidence of cesarean section more than 10% was considered significant, and 150 subjects per group were needed to detect this difference. A standard epidural technique was followed in both the groups. Epidural space was localized using an 18-gauge Tuhai needle using the loss of resistance technique. An 18-gauge epidural catheter was inserted. A bolus dose of 12 ml 0.125% bupivacaine was given, followed by a continuous infusion of a mixture of 0.08% bupivacaine and 1.66 microgram per ml fentanyl. The infusion was given at the rate of 10 ml per hour. All the mothers were monitored for pain, vital signs, and fetal heart rate by a continuous CTG at different points of time. The primary measure of outcome was to compare the incidence of cesarean section between the two groups. The secondary measures of outcome were to assess the duration of labor and the rate of instrumental deliveries apart from maternal satisfaction. Tests appropriate to the data were applied. Both the groups were comparable on most parameters except for cervical dilatation. The mean cervical dilatation was 2.7 centimeters in the early group and 4.1 centimeter in the late group. Maternal satisfaction was comparable between the two groups. The duration of labor, which was assessed by the initiation of epidural and delivery, was longer in the early group compared to the late group, and this was statistically significant. There was no difference in the rates of vaginal and instrumental deliveries between the two groups, but the rates of cesarean were higher in the early group compared to the late group, and this was statistically significant. However, the recent studies indicate when you initiate epidural has no effect on the operative deliveries. But the results of our study were a striking contrast. Does that mean in early epidurals mean more cesareans? So we further analyzed our results. The more number of cesareans were seen in the early group, and the commonest indication was failure to progress. But the recent ACOG guidelines state that prolonged first stage alone should not be an indication for cesarean section. Also, in special situations like women receiving epidural analgesia, longer durations of second stage may be appropriate, a natural consequence, and therefore acceptable. These results probably indicate that it is time for both the obstetricians and the anesthesiologists to consider the indications of cesarean section in the context of epidural during labor. Also, the other limitations were a smaller sample size and that the experience of the obstetricians was not taken into account. May I conclude that early initiation of epidural delays the progress of labor and increases the rates of cesarean section, which is contrary to the present evidence. Maternal satisfaction is higher with early initiation of epidural, though the results of our study were not statistically significant, and we presume that our results were influenced by obstetric practices. And hence, our trial opens scope for further studies where we would like to study a larger sample and observe the influence of variables like local obstetric practices and the experience of the obstetrician and observe whether or not they influence the outcome. Thank you.
Questions among the judges to clarify anything?
Points from yesterday what Dr. Shiv was teaching us regarding the how to present the slides. That is the only negative point.
That's quite. Is that a Mac?
No, I use the Windows PowerPoint, but it's
It does actually. It can change on the. I've seen that.
It can be changed. It can be changed.
Okay. No, at least on the projector. It can change.
All right. Just a couple of questions more.
Yeah, hi. I just have one thing to say. There is another confounding factor actually, possibly, is that severe pain early in labor is often indicative of a difficult labor ahead. So the woman who asks for an epidural at 2 centimeters is likely to have a difficult labor with or without an epidural, with a higher likelihood of a cesarean with or without an epidural. Whereas the lady who progressed to 5 centimeters before she asked for an epidural is one who probably would have ended with a normal vaginal anyway, with or without the epidural. So that bias is there.
Yes.
Thanks. Arvind is an expert in obstetric anesthesia. I've got Dilip also.
Hi, I'm not an anesthesiologist, but I think you're going to do bigger and greater things with what you're doing already. But if you're going to publish this, and I think you should publish it. You've done a lot of hard work. There's no reason to stop here. Can you go to your first slide? So here you're saying early versus late effect on outcomes. What was your? Can you go to the next slide, please? Keep going. Next. Yeah, hold on. So this is where was the one you said it's an observational study? Yeah, okay, great. So you are making an intervention, right? You actually made an intervention. So at that point, it stops being observational, right? So can you explain that?
All the mothers were given epidural analgesia, and we were just, in retrospect, first of all the mothers who requested epidural analgesia were given epidural analgesia. Then in retrospect, we observed. We divided them into groups in retrospect.
So then it's not prospective, right?
Look, no. I think... No, I got your point.
Send this across to people who are going to review this. You have to be very clear in your terminology. If you've made an intervention, early versus late epidural, it ceases to be observational at that point. Now, if you did it in retrospective, you have to say it's like a retrospective cohort study or something that makes sense from a statistical and terminology viewpoint.
I'll answer this. I believe that you didn't randomize into early versus late. So the mother chose when she wants an epidural, and the epidural was provided, which is the standard of practice. So they are observing the normal standard of practice. So I think hence it can still be considered as a prospective observational study.
So in that regard, so it's not like an intervention was made and designed by her?
No. So we go by, I think the standard is you provide epidural when the mother asks. Okay, and they just compared when the mother.
To compare the incidence of cesarean sections between the two groups. Those were all secondary measures.
Who's the third one?